Good afternoon, good evening. Welcome to this webinar, which is organized by Pentax Medical Asia Pacific. It is really a pleasure to be here because Pentax Medical has been a great supporter of endoscopic education in the region. And it's also my special pleasure and honor to introduce our speaker for today, Professor Lee Jun Heng, who's a expert in upper GI, both diagnostic and therapeutic endoscopy from the Samsung Medical Center and Sung Kyun Kwan University School of Medicine. And today, he'll be talking about the Imagina system, clinical experience, and some case studies as well. And so we'll have some Q&A after he's done his talk and a chance to discuss as well. So without further ado, over to you, Professor Lee.
Okay, thank you for your kind introduction. It's a great honor for me to talk about Pentax new system named Imagina. I'm here because I'm using both Olympus and Pentax at my institution. Actually, we have 4 Pentax Imagina systems and 28 endoscopes, Pentax endoscopes in my institution. So maybe I'm the person who has the most experience of Pentax Imagina system in my country. So today I'd like to talk about gastric cancer screening in Korea and Pentax Imagina endoscope and Splash M knife. My topic today is gastric cancer screening in Korea and Pentax Imagina endoscope and Splash M knife. For the first topic, I'd like to split my talk into 2 parts. The first is a screening program and the second is outcome. This slide shows the Korean cancer statistics. As you can see, gastric cancer is the most common malignant disease in male and number 4 in female. The incidence of gastric cancer in Korea is slowly decreasing, but the treatment outcome, the mortality, is very rapidly decreasing. The mortality and incidence ratio in Korea is 0.31, which is the best outcome in the world. This picture shows the estimated gastric cancer incidence and mortality rate in 2012. Korea and Mongolia is number 1 and 2 in the incidence of gastric cancer, but the outcome is the best in Korea, followed by Japan. I think it is probably due to the screening and treatment. This is the brief overview of Korean cancer screening program. In 1996, 10-year National Plan of Cancer Control was launched. In 1999, National Cancer Screening Program for stomach, breast, cervical cancer started for members of a lowest income family. At that time, it was free of charge. In 2005, target population was expanded to the lower 50% of national health insurance. And in 2006, screening for upper 50% income group started with 20% self-payment. So right now, we have been doing all Korean people screening for more than 15 years. So there are 2 systems running together. One is National Cancer Screening Program, and the other is National Health Insurance Cancer Screening Program. The National Cancer Screening Program is for members of a poor family. Everything is poor. Free. National Health Insurance System is for rich people, and they should pay 10% of the all screening charges. Most of the public budget comes from national health insurance. It is about 90%. And the national government and the local government pay 5% each. Regarding the government structure, National Cancer Center develops the screening strategy. So this is the recent screening program for 5 major cancers. It is stomach, liver, colorectal, breast, and cervix. For gastric cancer screening program, it starts at the age of 40. The interval is every 2 years. The standard method is, of course, endoscopy. If endoscopy is not available, upper GI volume study is the secondary choice. The most important issue in Korea is the screening interval. Currently, 2-year interval is recommended. And the second issue is the upper age limit. In the academic guideline, the upper age limit for gastric cancer screening is 75 years. However, in the government program, there is no upper age limit. The policy change seems to be very difficult for government officials. All kinds of medical institutions participate in the gastric cancer screening program. General hospitals, small hospitals, primary clinic, and special screening institutions are doing all the screening endoscopies. One special aspect of Korean cancer screening is opportunistic private screening. It is not a national public mass screening program. It is a personal private program, and the cost is not covered by the government, and it's usually expensive program. The proportion of opportunistic private screening is about 30%. The participation rate of gastric cancer screening for the organized national program is about 45. Including the opportunistic private screening program, the overall rate is about 75%. In the gastric cancer screening, the rate of endoscopy is about 80%, and upper GI volume study is used about 20%. Gastric cancer detection rate by National Cancer Screening Program is about 1.4 out of 1,000 examination during 2002 and 2011. In that period, endoscopy and upper GI series was done half and half. When the screening is done by endoscopy in special center, the gastric cancer detection rate is about 3 out of 1,000. Among them, 75% is early gastric cancers. Okay, this is the outcome. Outcome of early period of National Gastric Cancer Screening Program was evaluated. And the recently published in the Gastroenterology Journal, the primary outcome was gastric cancer specific mortality. In average, the gastric cancer specific mortality reduction was 21%. In the age group between 40 and 74, the rate was 47%. So, in our early experience, half of the gastric cancer deaths can be prevented by National Cancer Screening Program. In subgroup analysis, the method and frequency matters. The mortality reduction was 81% by repeated endoscopy and 21% by repeated upper GI series. So endoscopy is much better than barium study in Korean cancer screening program. By endoscopy, the effect of mortality reduction remained by 48 months from the cancer diagnosis to the last screening. So we think this data supports 2 years interval. Okay, from now on, I'd like to move on to the second topic, which is Pentax Imagina and I-10C gastroscope. Pentax company entered the endoscopy market in 1976. The company is famous for its innovation in the history of endoscopy. For example, electronic radial array EUS was firstly developed by the Pentax in the world in the year 2001. Personally, I met the Pentax endoscopy in 1998 when I was a Navy physician. As you know, Korean doctors, men doctors, should serve the military for 3 years. As you know, this is a typical case of situs inversus. 2 years ago, Pentax company launched a new series of endoscopy system named Imagina. For the improved workflow efficiency, Imagina system adopted user-friendly iPad-style touch screening control. It is very useful and, of course, very fun. A lot of fun. For the image-enhanced endoscopy, it has eye scan, surface enhancement, tone enhancement, and contrast enhancement function. This is upper endoscopy named I-10C. I-10C has new control body and angulation design. The previous version of Pentax endoscopy was a little bit heavy, but the new gastroscope I-10C is very small and light. The weight is less than most products from Olympus and Fujifilm. I-10C has new control body and angulation design. The previous version of Pentax endoscopy, and I love the angulation function of I-10C. The name is further angulation range. The angulation range of Pentax I-10C is much more than endoscopes from most other companies. The distal tip has two LED light sources. They say that the life expectancy is long enough, so the running cost is reduced. There is a water jet function and next generation HD image sensor, so the endoscopic image is really good. I10C has excellent image quality, especially in the closed-up view. The ampulla of Bata is beautifully seen in the left side picture. The working channel of I10C gastroscope is 3.2 millimeter in diameter. This is very important, 3.2 millimeter in diameter, because there is no 3.2 diameter working channel in recent versions of endoscopes from Olympus and Fujifilm. Only Pentax I10C has 3.2 millimeter gastroscope. This is the reason why I love Pentax I10C for gastric ESD. With an ESD knife and other catheters in the working channel, air-water suction is possible, so the procedure is much easier. The direction of working channel is very similar to Olympus. One difference is the direction of water jet. Water comes from 7 o'clock direction. For Olympus, it comes from 5 o'clock. This is also good. There are two USB ports in the Imagina system. This educational slide shows how to enter the stomach from the esophagus. You can make this kind of educational material with the Pentax video clip. It's really easy, so it's very convenient. So as a summary about Imagina, advantage of Pentax Imagina system and I10C gastroscope, it has a lightweight 3.2 millimeter diameter working channel, and the angulation is good. Close-up image is very clear, and it also has eye scan image enhancement function and USB memory ports. So I'll show you some images. This is atrophic and metaplastic gastritis. This is a typical hypoplastic polyp on the gastric antrum. As you can see, I injected some submucosal solution and cut with a snare. This is submucosal tumor. As you can see, the overlying mucosa is normal, and you can see the fine vascular network pattern very clearly. The two light is an LED source at the distal end of the I10C endoscopes. This is a very interesting case. A 45-year-old male was referred due to suspicious cancer lesion near the cardia. But when I reviewed the endoscopic images, it was not a neoplastic lesion, but a vascular lesion. And there are multiple angiodysplastic lesions in the esophagus and hypophyseal findings. I do follow-up endoscopy with Pentax Imagina I10C gastroscope. As you can see, there is a pale area with vascular markings in the middle. When I turn on eye scan, you can see the vascular patterns more clearly. This is not a magnifying endoscopy. It is just regular Pentax I10C endoscope. There are angiodysplastic lesions in the antrum, esophagus, and hypopharynx. I compared the upper images are Olympus magnification zoom endoscopy images, and you can compare with the regular Pentax Imagina I10C gastroscope. Because the close-up image of Pentax I10C is so good, I think we don't need zoom endoscopy anymore. Just I10C is enough to observe the fine vascular network patterns. This is a duodenal ulcer. You can see the edematous ulcer margin very clearly, and the follow-up was done with an Olympus endoscope, and you can see the image quality of two products very clearly. This is multiple duodenal adenomas in a patient with familial adenomatous polyposis. The flat elevated adenomatous lesion is very clearly seen. As you know, this is a Bowman type 4 advanced gastric cancer. When I entered the stomach, I immediately found a mosaic pattern of thickened gastric fold. But the abnormality was limited in the body, and the antrum, the mucosa, was almost normal. So the Bowman type 4 was limited in the fundus and body. In retroflexion, you can see the thickened fold. The interval between fold and fold is very close. And the stomach does not expand with air because it became very steep. When I go close, I can see the abnormal mosaic pattern very clearly like this. So this is a typical case of Bowman type 4 observed by Pentax Imagina I10C gastroscope. This is a really nice image. My next topic is ESD for EGC with Pentax Splash M knife. Splash M knife is a multifunctional ESD knife from Pentax. It has a needle type tip with a hooking mechanism. At the distal end of the knife, there is a metal plate which is useful for bleeding control even in retracted position. The length of the ESD needle is about 2 millimeters in extended position and 0.5 millimeter in retracted position. In my personal experience with the Splash M knife, I found 3 advantages. First is the hooking mechanism. The hooking mechanism is very useful for the submucosal dissection step, especially for doctors who have done the ESD with IT2 knife. I usually used dual knife and IT2 knife for almost all patients, but recently I'm using only splashy M knife. And I can do the procedure without using IT2 knife because of the hooking function of the M knife. The second advantage is metal plate at the distal end of the splash M knife. It provides enough contact area for the bleeding control. Finally, the procedure time is usually much saved due to the water jet function. In a recent study from Japan, ESD using splash M knife appears to reduce the use of hemostatic potion after the gastric ESD. It can reduce the total cost of the treatment. This is my typical case with the splashy M knife. This is a really interesting case. A tiny, pale, slightly elevated lesion was found in the screening endoscopy. And the biopsy was atypical glands with high-grade dysplasia, highly suggestive of tubular adenocarcinoma fundy gland type. The background mucosa was normal, no atrophy, no diffuse redness. In the forceps biopsy, at least 2/3 of the specimen was well differentiated adenocarcinoma. In the high power view, the cellular atypia is not prominent, but the glandular structure was deformed. Structural abnormality. I talk with the patient about the endoscopic treatment of a highly possible gastric cancer, and the procedure was done like this. You can see the lesion in the 9 o'clock direction. In close-up view, it looks like a small, depressed ulcer scar-like lesion. I made a marking with the splash M knife. Submucosal before initial step is a circumferential cutting. Of course, there were some bleeding as expected. I did the bleeding control. In this case, I used both splash M knife and Olympus IT2 knife for efficient treatment because the location was so difficult. Anyway, the procedure was done as expected. This is the resected specimen. The final pathology was a 5 mm sized fundic gland type early gastric cancer and limited in the mucosal layer. Just like the forceps biopsy, individual cancer cells does not look so bad, but you can clearly see the structural abnormality like branching, torsion, and back-to-back appearance. The cancerous gland was limited in the mucosal layer. They touch and push the muscularis mucosal layer, but there is no evidence of submucosal invasion. In the follow-up endoscopy, you can see the ESD-induced ulcer in the high body posterior wall. Giemsa staining for Helicobacter pylori was negative. So we concluded that this is a typical case of Helicobacter negative gastric cancer. I'll show you one more case of ESD for EGC with the same splash M knife. The initial diagnosis was tubular adenoma of the stomach, but the histology showed suspicion of adenocarcinoma. So there is a small depressed lesion on the greater curvature side of the proximal gastric antrum. Left side is white light endoscopy. Right side is NBI image of Olympus. This is the biopsy. In the close-up, you can clearly see atypical cells, which makes a glandular formation. So adenocarcinoma, and I think it is moderately differentiated tubular adenocarcinoma. So I explained in Korean in more detail about the treatment benefit, endoscopic treatment benefit to the family members. And this is how I draw and explain to my patient about the possible procedure. This is my usual setting. Pentax Imagina system, I10C gastroscope. I usually use Korean-made fine Medix injectors. I chose Pentax Splash M knife for this case, and electrosurgical unit is Elbe Bio 300D. I use mainly endocut I mode, effect 3, duration 3, interval 3. For the bleeding control, I sometimes use a hemostatic forceps, but when I use Pentax Splash M knife, more than half case, I don't need hemostatic forceps because Pentax Splash M knife is very good for bleeding control. The sedation is petidine and midazolam 5 milligram. So this is a lesion. There is a small depressed lesion on the greater curvature anterior aspect of the gastric antrum. In close-up view with eye scan, you can see the irregular mucosal pattern and depressed lesion. I usually spray indigo carmine before marking the lesion. My personal preference. I started marking with the Splash M knife. I usually start the circumferential cutting from far side first and close side later. So I did the circumferential cutting in the middle from the behind. Some more injection, and I do submucosal dissection using the same Splash M knife. This is the final image of my procedure. Okay, let's see the video. As you can see, there is a small depressed lesion like this. I use a transparent hood for the procedure. When I see a closed-up image, I sometimes use image enhanced function named eye scan in Pentax. I can guess the lateral margin very well, but for my personal preference, I usually spray indigo carmine before I make markings like this. press a little bit and use spray current. I finished the circumferential cutting and injection. As I said you before, I start from behind. So submucosal injection about 50%, and I start to do circumferential cutting like this. This is a push technique. I sometimes use pull technique or sometimes use push technique. So additional injection with the saline mixed with indigo carmine. I cut the proximal part. Press a little bit to cut the muscularis mucosa very clearly. This is how I use the hooking mechanism. I start from behind and pull a little bit and cut. So I use the pulling pressure. Okay, when I see some bleeding during the procedure, I immediately can hemostasis like this. Some mucosal water injection is possible with the splashy M knife. So you don't need to change the catheter in the middle of the procedure. Everything from injection and hemostasis you can do only with this single knife. So that's why we call it multifunctional ESD knife. Post injection, cutting, and submucosal dissection, hemostasis is all possible using splash M knife only. I use the hooking mechanism. Okay, this is almost final cutting. After the final cutting, I push the sample to the fundus and check whether there is a residual bleeding, and I make bleeding control like this, and the procedure is all set. Because you don't need to change the catheters, much time is saved. It saves a lot of time. So very good for our busy endoscopy unit. So the pathology was a moderately differentiated adenocarcinoma. The long diameter is 11 millimeter, and happily the cancer is limited in the mucosal layer, and there is no lymphovenous invasion. So the pathology outcome is curative. This is the pathology. You can see the moderately differentiated tubular adenocarcinoma with moderate cellular and structural atypism. Okay, this is the end of my slide. So the advantage of Pentax Imagina I-10C gastroscope and splash M knife is good closed view, excellent angulation, and 3.2 millimeter working diameter. So thank you very much for your attention.
Thank you very much, Professor Lee. Really nice talk and nice cases that you showed us. We can take some questions now from the audience. I don't see any yet. So perhaps maybe Professor Lee, can I ask you some questions first about the Korean gastric cancer screening program, and also later about the Imagina system. I wanted to ask you about H. pylori eradication. Is that covered by the Korean health insurance system, even if there is no pathology. For example, no ulcer and no cancer. Can you just will the system pay for eradication just for gastritis or prostate case?
It's a very good question, but however, our government cover only the patient with ulcer or cancer or idiopathic thrombocytopenic purpura. So in other patients with just gastritis, intestinal metaplasia, the Helicobacter treatment is not covered by the government, and the patient usually pay themselves. So the most common first-line treatment is PPI-based amoxicillin clarithromycin treatment for 2 weeks, and the medical fee is about 60 US dollars for 2 weeks medication fee. 60 USD dollars.
Wow, that's quite a large, quite expensive, huh?
Yeah,
but,
so 2 weeks medication, $60 US dollars. Yeah, the patient pay themselves.
Okay, this I remember this was the situation in Japan for many years, and then eventually after many studies showed that eradication of HP does reduce gastric cancer incidence, they finally agreed to pay for non-ulcer and non-cancer eradication. And I guess hopefully that will happen for Korea as well. Huh?
Yes, our National Cancer Hospital is organizing the nationwide prospective study, and the enrollment is already finished, and we are expecting the outcome in the near future. So as you mentioned, after we can see our own prospective study result, maybe the government will pay for every Helicobacter pylori treatment, but not yet. So we should wait a few more years before the government pay all the medication of Helicobacter pylori treatment.
Thank you very much, Professor Lee. I'm seeing a question from the audience. Could you share with us about your setting for eye scan?
So eye scan setting is there are many, you can choose many settings. So surface enhancement and contrast enhancement. I usually use 3 and 3, but every other doctors have their own choice. So the options of eye scan setting is very free. So everybody can choose their own setting. So in my opinion, it has some pros and cons. For example, Olympus MBI is just push, touch, and out. But Pentax eye scan, you can set every different settings. So it is very difficult to compare the outcome of diagnostic efficiency. So every doctors are using different setting. For me, I use the surface enhancement setting 3, contrast enhancement setting 3. That is my private setting. Okay.
And thank you, Professor Lee. And in your practice, do you do most of your examination is done in white light, or do you use one of the enhancements or settings for your main screening, main examination?
So for the general examination, actually we don't need the image enhancement so much. just white light endoscopy is enough to find the most small lesions. But when you find the small lesions or even big lesions, you can use image enhancement for characterization. So for your question, I can say that white light endoscopy is usually enough for most cases. But when you find a lesion, image enhancement function like eye scan much helps.
Thank you very much. Professor Lee, what is the diameter of the I10C gastroscope?
I10C gastroscope
Outer diameter, yeah.
Outer diameter is about 9 millimeter, 9.3 millimeter. Yeah, thank you.
Wow.
I asked the
That's very
Pentax
slim.
people, and they say it is 9.3 millimeter in outer diameter. But what is important is the working channel diameter. So working channel diameter is 3.2 millimeter. That's the reason why I choose Pentax I10C endoscope for my ESD procedure.
That's actually, it's very impressive, I find, because 9.3 outer diameter is super slim.
Yeah,
because
very
most other gastroscopes are 9.7, 9.8 millimeters. For example, the Olympus HQ190, which many countries use. But none of them actually has all of them have a working channel of 2.8 millimeters. So Pentax has managed to include a large diameter working channel in a super slim endoscope.
Professor,
so that's really very impressive.
I'm sorry, I will check again to the Pentax people. So what is the outer diameter exactly? I'm sorry. I'm sorry. I checked again, and the answer is 9.8 millimeter. Is that right? Yeah. I'm sorry. I will. Yeah, 9.8 millimeter. I'm sorry, Professor.
No problem, no problem. But still, it's very, so it's the same as most of the other diagnostic gastroscopes, but certainly with the large working channel, that's a huge advantage, as you mentioned, because
so
you
the
can
LED
do good suction. Yeah.
LED light at the end of the distal tip, because of the LED light, the image is very bright. So one concern is that how long it will go. Usually LED light is very long, about 10,000 hours, they say, but I am using it for 2 years, so I don't know how long it will go. Anyway, they say
Okay,
10,000
still
hours.
no breakdown, huh?
We still don't know. We should wait.
Fantastic.
Yeah, until now, no problem.
Yeah, can I ask the audience to please send in your questions, because I'm still not seeing any other questions now. Professor Lee, I wanted to ask you also, in the Korean system, what is the stage for gastric cancer? What percentage of cases are stage 1 at diagnosis?
Stage 1. I'm sorry, I don't know exactly, but we interpret whether it is early or advanced. So in recent data, the proportion of early gastric cancer is 72% in our Korean screening program. So
Wow.
stage 1 or 2, I don't know exactly. And when we found early gastric cancer, when we find the gastric cancer in early stage, about half is treated by endoscopy. So in general, 2/3 is treated by surgery, and surgery patient, half is advanced and half is early. So we treat 1/3 of all gastric cancers. So this is how we are doing in our country recently.
That's very impressive, and it means that your proportion of, it sounds like your proportion of stage 1 cancers is at least 1/3, maybe more than that. Huh?
But yeah, maybe much more than that, because undepression type cancers are more frequently treated by surgery than endoscopy. So I will let you know later. I'm sorry about that.
That's okay. Thank you very much. I saw also that you would one of your cases that you showed was a funded gland carcinoma, which is very uncommon. Do you see many of those in Korea, and roughly what proportion of all your cancers are, funded gland type of adenocarcinoma?
Funded gland type adenocarcinoma is very rare. So in Korea, the Helicobacter pylori positive rate among gastric cancers is about 99%. So funded gland type cancer is one of Helicobacter pylori negative cancers. So in our hospital, we usually treat 2,500 gastric cancers every year. In endoscopy unit, we treat 1,000 cases each year, and funded gland type cancer is less than 5. So it is quite rare.
Thank you. Thank you for sharing that. Oh, and so every year there in your hospital, there are 1,500 surgical cases, gastrectomy?
Actually, more than that. So anyway, about 2,500, about 3,000 new cases, and some patients in advanced stage, a small portion, they are treated by chemotherapy, and excluding them, about more than 2,500 cases are treated by surgery or endoscopy. It is about 12% of all gastric cancers in Korea.
Wow, that's fantastic. It's a huge number. I think if I remember correctly, in Seoul, the city, perhaps maybe is it true that half of all gastric cancers are treated by the hospitals in Seoul?
Okay, the population of Seoul is 1/4 of all Korean population. And regarding cancer, I don't know exactly, but at least it is about 40% or more. Yeah.
Because everybody comes to Seoul. A lot of people come to Seoul to get their cancer treated, huh?
But our local hospitals are also very good, and the concentration is a big problem, but it is not as high as 50%. I guess it is about 40%.
Well, that's still a huge number.
That's still huge.
That's still a huge number. And I remember from visiting your hospital previously that it's, to me, it's really one of the most beautiful hospitals in the world, the Samsung Medical Center. It's
thank you very much.
Amazing place.
Thank you very much.
I don't know if there are any more questions from the audience. To the organizers, have you seen any more coming through?
Yeah, Dr. Kaur, there is one question regarding submucosal lifting agents. The audience wants to know their opinion on whether injecting hyaluronic acid or
Hyaluronic
adrenaline,
acid.
yeah, which does
Right. Because Professor Lee, you mentioned that you use saline injection, but do you make use of more viscous injection agents like hyaluronic acid or even gelifusine or glycerol perhaps for your
Yes,
more
we
longer
also,
cases?
yeah, okay, good question. We also use hyaluronic acid and other solutions for submucosal injection. But for me, just saline and a few drops of indigo carmine is usually enough. So our young beginners, they require longer time. So in that case, they choose hyaluronic acid for submucosal injection. But my procedure time is not so long usually, so I think saline mixed with a few drops of indigo carmine is usually enough for most of my cases. So it depends on the speed of the procedure of each endoscopist.
What about for tougher cases where there's a lot of fibrosis? Do you move to a thicker, longer lasting injection solution?
Of course, when there is a submucosal fibrosis or when a lesion is located in difficult location, I also choose a hyaluronic acid for submucosal injection. Of course, so it depends on the doctor and the cases.
Okay. And so is this muco up or do you have another preparation for Korea?
We usually use hyaluronic acid and saline. Mostly use 2 cases of submucosal solution. Other solution, there is no commercial thing in Korea, I guess.
Okay.
I think.
So is your solution already pre-mixed for endoscopic use, like mucoab, or do you have to mix it yourself from the orthopedic preparation?
Yeah, we use mix in our endoscopy unit by our nurses.
Okay. Thank you very much. And do you put adrenaline inside as well? A little bit of adrenaline?
Yeah, a little bit. Yeah. So saline and epinephrine and a few drops of indigo carmine is the standard.
Okay, thank you very much. Thank you very much, Professor Lee. Terrific talk. Very nice cases and very nice demo of the Pentax Imagina system. I think the other point that you showed also is the retroflexion angle of the tip of the gastroscope as well. That looks really amazing, and I guess you will find that very, very useful also for cases for ESD, also in the lesser curvature and in the upper body of the stomach as well, right?
Right. So angulation is very swift and angulation angle is really good. So I love it.
Thank you very much. Well, Venkatesh, do we have any more questions from the audience for Professor
just one
Lee?
more before we wind up, Dr. Kaur, and the question is, would you please address on how to remove the burn tissue at the tip during the procedure? Probably this is pertaining to flash-M knife. I'm not too much sure. How do you
the burn
remove
tissue?
the burn tissue? Yes, during the procedure.
Okay, is that from the knife, right? Not from the scope?
I guess so. Yeah.
Okay.
It's not clear, but that's what it is here.
Okay, Professor Lee.
So the question is about knife.
Removing the burn tissue from the knife. I guess do you use any cleaning solution, or do you just does your assistant just wipe it off once you pull it out of the channel? Is there some special cleaning solution for the burn tissue on the knife, the charred, blackened tissue? carbonized tissue on the knife.
I'm sorry, I don't understand the question exactly.
I think the question that was being asked is because when we use probably more coagulation current for hemostasis, there is some black material or carbonized material on the tip of the knife, and sometimes it can be hard to remove or to clean off. Is there any special technique or cleaning to clean the knife?
When we do the hemostasis using splash M knife, of course some dark black thing adhere to the tip of the splash M knife. Yes, of course, we sometimes should clean with wet gauze after removing the M knife. So it sometimes happen, but not so much for me. Yeah, sometimes we should remove the splash M knife, and my nurse clean the tip with wet gauze. It sometimes happen. Yeah, of course. No special technique.
Okay. Thank you very much. Thank you very much. I guess that's probably the last question, and it just remains for me to thank Professor Jun-Heng Lee for the terrific talk, case demo and discussion, and Pentax Medical Asia Pacific for sponsoring and organizing this webinar. Thank you very much, and I think if you have any further questions, please submit to your national Pentax representative, and they can forward to Professor Lee. Thank you very much.